Thank you very much, Chris, and thank you for the invitation to come and talk this morning at a meeting of Pathfinder GPs at a very timely stage, clearly, in the development of the government's health policy and the refashioning of the health service that is planned by the Secretary of State. I should begin, I think, by congratulating the King's Fund on their timing. This was there must have been a sixth sense there somewhere that suggested that this would be a good moment to take stock and to look at how we take the process forwards. It's obviously, as it's turned out, been perfect timing because the listening exercise is designed at exactly this moment to ensure that all the voices are heard about what's good, what's right, what's constructive, what's important in what's going on, and how the process can be strengthened in order to ensure that it delivers the objectives that we all have for it. I said when I sought the support of my parliamentary colleagues as the elected chair of the Health Select Committee last summer that I would propose to adopt the approach to politics advocated by Joe Grimmond. You may remember a former leader of the Liberal Party who said, if you want to make a difference in politics, you have to march resolutely towards the sound of gunfire. That was the way in which I have set out to lead the Select Committee, although I'm bound to say at this moment I don't find it a very useful stage direction because I feel we're surrounded in a 360-degree compass by the sound of gunfire. So what I'm going to talk about this morning is less the politics and more the substance, I hope, of what is going on in the health service and what we should be seeking to do to take the service forward, starting from where we are. And those who've heard me speak before in recent times about what's going on in the health service have heard me refer to the fact that there are two different definitions of the radical changes that are going on in the health service at the current time. There's the definition which is favoured by those who occupy the Gothic splendours of the Palace of Westminster, which is that they believe that there is a radical process of change going on as a result of the legislative process. There is a process of change there, but I think the true radicalism of what's going on in the health service at this moment is actually not encapsulated in the bill. It's encapsulated in something more different and more fundamental, and it's what I sum up by referring to it as the Nicholson Challenge, named, of course, after Sir David Nicholson, because he first articulated it 12 months before the general election when he invited the health service to look forward to the first half of the current decade and recognise that the increase in resources that the health service has grown used to at a higher rate in the last 13 years under the previous government, but the habit of increasing resources that has been part of the history of the health service writes its foundation in 1948. If we look forward to the first half of this decade, for reasons that we're all familiar with, the growth of resources available for healthcare during the first half of this decade is going to be at an historic low. The government is committed to real terms growth. It's very tiny numbers in terms of real terms growth. In effect, it's a flat real terms budget for 4 years during the lifetime of this Parliament. And you make decisions as a government about the budget for the health service, but you make, of course, no decisions at all about the demand for healthcare. That's driven by completely independent factors. Demand for healthcare, we should assume, will continue to grow by 4% per annum, as it has done throughout the history of the health service, but resources in real terms won't, in practical terms, grow at all. So for the first time in the history of the National Health Service, we're going to try to meet growing demand for healthcare running at 4% per annum out of a flat real terms budget. You don't need an MBA to work out that means that you have to deliver 4% efficiency gain 4 years running if we're going to meet the demand for healthcare during the lifetime of this Parliament. And just to put that in its context, The NHS has never delivered 4% efficiency gain in a single year of its history, and I've challenged Chris Ham at the King's Fund and others in the healthcare world. I've so far not been shown any example of any healthcare system anywhere in the world that has delivered 4% efficiency gain 4 years running. So if you want a definition of radicalism, it doesn't seem to me they come better than that. We're embarked upon trying to do something that no one has ever done before, to meet demand for healthcare by achieving efficiency gain on a scale that is quite literally unprecedented. And I'm very strongly of the view that whichever of the particular points of departure you come from in discussing the current health debate, that's the commitment that is going to make the weather. When we write the history of this government's record on healthcare, we will remember, of course, the legislative changes and the framework, but what will actually make the difference about the record that's delivered is whether we succeed in delivering that unprecedented improvement in efficiency, 4% efficiency gain 4 years running. If we do deliver it, we've delivered something no one's ever done before, and if we don't deliver it, we either have a road crash or we fail to meet demand for healthcare. The two things amount, in truth, to much the same thing. So I start, and I apologise to those who've heard me going on that subject before, but I've taken to drawing a parallel between my current speeches on the National Health Service and the speeches of Cato the Elder to the Roman Senate in the 1st century BC, when he finished every single speech he made with the phrase, "and Carthage must be defeated." Well, today's health service equivalent of the defeat of Carthage is that the Nicholson challenge has to be met, because that's what makes the weather. That's the first point I want to make. The second point I want to make comes at the same issue, exactly the same issue, but from a fundamentally different point of view. Because I've talked about the Nicholson challenge as a health economist. I've talked about it in terms of demand and resources and efficiency. If you address exactly the same issue from the point of view of a doctor or a nurse seeing patients and ask, how do you deliver efficient healthcare that meets the quality standards that we all want to deliver for the majority demand placed on the health service at this moment, I think there's an important opportunity to bring the two perspectives together to define something that it's required not just for the economic reasons that I've gone through, but also for the clinical reasons of the design of the healthcare system that we need for the future. I think everyone in this room is familiar with the paradox that healthcare policy is made by normally healthy people who think they're the typical patients of the health service. That is to say, people who present for an episode of care, the episode is completed, they walk out healthy, they think that that is what the health service does, because that's the typical patient of SW1. Everyone in this room will be familiar with the proposition that those people who think they're normal are actually truly abnormal in the context of the National Health Service, and that what we should be doing is not designing a system, as we tend to, that responds to the experiences of the abnormal patient who occupies SW1, but a system that meets the core demand of the health service efficiently and effectively, as well as, of course, as meeting the demands of the patient who needs an elective procedure, to put it in simple terms, either a primary care consultation or a follow-on elective procedure. And the majority demand placed on the health service of people with long-term complex conditions, often associated with mental illness or old age, and whose requirements of the service are fundamentally different from those of the abnormal patient who comes to the policy discussions in SW1. How do you meet that demand, the demand of those majority patients of the health service? Chris Ham has been a long-standing advocate of a point of view that I think is very broadly shared right through the health service, that we need to deliver a service which, instead of being based on traditional silos, where you have a primary care service and you have a community health service, and goodness knows what the difference between those two is supposed to be except for their history. You have a primary care service, you have a community health service, you have a hospital service that is too often divorced from the community health and the primary health service, and you have a social care system that is run through a completely different system of political accountability. How on earth do you get those four, and you could list half a dozen other subsets of these silos, to coordinate properly in order to deliver a service that works for the individual patient whose needs are complex, ongoing, and are not easily summarised in what used to be referred to as finished consultant episodes. It's their life we're talking about. It's not an individual course of treatment for an individual separable condition. So delivering integrated care that's designed to meet the needs of an individual patient rather than brigaded into management silos, that is the core challenge, in my mind, of the National Health Service as we look forward during the lifetime of this Parliament. And I would emphasise again, achievement of that, of a step change, an order of magnitude change in the degree to which we achieve proper integration of the services delivered to the majority demands placed on the National Health Service. That is the central challenge facing the health service at this moment. And it is also the only way of meeting the Nicholson challenge, the 4% efficiency gain 4 years running, because our silo-based traditions for the delivery of health and social care don't merely deliver poor care because people fall through the gaps between the silos. They also deliver expensive care because patients are repeatedly asked the same questions. You get slightly different answers from them on different occasions because very often they're slightly deaf or they think they're being asked a different question. You don't capture the information, or if you do, you don't pass it into the next silo. The budgetary pressures on the different bits of the system are different. So there's game. We're all familiar with the problems. It delivers poor care and it delivers expensive care. And if we're going to deliver 4% efficiency gain 4 years running and deliver better care to patients, we have to achieve a radical, if I can use that word, and it's a word I normally back away from because politicians love to describe themselves as radicals. But actually, 4% efficiency gain 4 years running is inescapably unprecedented, and the only way of achieving that result is to achieve an unprecedented change in the clinical model of care delivered by the health service, which focuses not on the minority interests of the abnormal patient from SW1, but on the majority interests of the patients who actually use the services of the health and social care system. And that's the central challenge. I'm very, very strongly, the government is quite clearly in some short-term political difficulty, if I can put it that way, around the bill that is currently before Parliament. And I think that the core reason for some of the difficulties that it's encountering is there isn't sufficient clarity about what is the problem we're trying to solve. And I hope you feel that in encapsulating it in the form of the Nicholson challenge that I started out with, and then describing the urgent requirement for a fundamental reshaping of the model by which care is delivered in order to deliver a more integrated, a more community-focused, less dominated model of care that is less dominated by the traditional acute sector silos. That's the definition of the challenge that actually defines what it is we're trying to do. And it's important when you're trying to solve a big problem that you understand first what the problem is you're trying to solve, and secondly, have some idea of the direction of travel that you need to achieve if you're going to solve the problem you've defined. And I've sought, in what I've said so far, to set out what I think the problem is and where I think the solution lies, and why I think it's a solution which should engage those who work in the health service, the clinicians and the whole staff, including the management staff of the health service, because what we're seeking to do is to change the way care is delivered in a way that I've been involved in this world now for 20 years. I was first a junior health minister in the summer of 1990. And for the whole of that period, people have talked to me about the need to achieve greater integration, greater collaboration between the traditional silos of the health service. We've talked about it. We've had various different slogans for it over the years. But it's been one of those things that's been much more talked about than delivered. And if we're going to rise to the challenge we now face, we now have the urgent drop-dead requirement to deliver a degree of integration that we've talked about but never succeeded in delivering. I think perhaps I'll stop there and let's get a discussion going as to how successful we are or what are the key building blocks to the delivery of that narrative, or indeed, is it the wrong narrative? Have I got the wrong end of the stick?
The key question that many people are asking is integration is about collaboration. The core of the bill and the reforms is about markets and extending the competitive principles. Can we reconcile those two? Can we ride two horses at the same time?
Well, let me address that question, and then perhaps we'll throw it open to the floor. But my answer to that question is that you have to be clear, as I've already said, what is the problem, what's the solution you're seeking to build. I won't repeat myself. I hope I've made that clear. Is that compatible with the continuation of discussion about competition? I would argue it's not compatible with an obsessive commitment to introduce competition at every stage in the process. Absolutely not. But equally, let me ask you to consider the counterfactual. Do we want to move into a world where people with alternative ideas don't have their ideas heard? I'm in favour of what we used to call a purchaser-provider-based system, or these days we call a commissioner-provider-based system, because it provides public money for the securing of access to high-quality healthcare based on need, and it provides a budget that the commissioner then is charged with using to deliver that objective, the objective I've set out to describe, as effectively as possible. Should a commissioner be deaf to alternative ways of solving problems? I take that as a rhetorical question. It's not merely rhetorical. It's the proposition that a commissioner should be deaf to alternatives is something that would be an improper use of public funds. You can't use public funds on the basis that I know the answer and I'm not interested in anybody else's potential solution. So, of course, the commissioner should be open to alternatives. But is it what you then have to move on to is it's no good having solutions that are offered that don't deliver the objective that you begin by describing. So is it impossible to have commissioners who are open to alternatives and still deliver integrated, properly collaborative packages of care? I don't think it is impossible, and nor do I think it's actually unusual in the economy outside healthcare. Modern sophisticated supply chains are built by listening to alternatives, but then insisting that all the different players in a supply chain work together on a committed basis. But what you can't, the danger is that we have a system that is too transaction-based, that seeks to define competition around smaller and smaller transactions. What we want is competition for solutions, not competition for individual transactions.
Thank you, Stephen.